Thank you, Sania, again, for your willingness to do this. She is the Special Assistant to Pakistan's Prime Minister and Federal Minister for Poverty Alleviation and Social Safety Ministry. Dr. Nishtar has been a former health minister, really a global leader, has co-chaired the World Health Organization's High-Level Commission on Non-Communicable Diseases. I think that was about 3 years ago. It's hard to remember now in the pandemic age. It all feels like a different lifetime. But they laid out some really critical recommendations for how the world needed to tackle non-communicable diseases. She was a runner-up for the Director General job for WHO, one of the finalists, co-chaired a commission for the National Academy of Medicine that I had the pleasure of serving on under her leadership on quality of care for low and middle income countries, and really what do we need to do to go beyond the access as the main problem to really be thinking much more broadly about health systems in low and middle income countries. And during the pandemic, Dr. Nishtar has really been one of the leading voices in how the intersection between diseases, pandemic, and social safety net interplay. And so there's really nobody better to give us insights on what the lessons from Pakistan are for this pandemic. For this session, I'm actually going to turn it over to the person who's going to be moderating for us, is Beena Sarwar. She is a journalist from Pakistan, has taught journalism at Princeton and Brown and Harvard, and was telling me about a new recent initiative on South Asia peace that we'd love to learn more about and hear more about. So Beena, thank you for moderating, but I wanted to welcome everybody back. This morning, we heard from the field about experiences in other South Asian countries. And so, Sania, your keynote lunchtime speech is really particularly timely. And again, thank you for doing this on a late Friday evening. Over to you, Dr. Nishtar.
Well, good day, everyone, and thank you, Ashish. It's wonderful to have the opportunity to speak to you. And I want to thank you for convening this important event. When I received, I really wanted to be here in person, but as I just mentioned, we voted on a very important Senate bill today, and I needed to be in the Capitol in order to cast the vote. Look forward to other opportunities, hopefully soon. I know that this is a South Asia event, so you must have talked a lot about cross-country comparisons and statistics, and data and statistics around the pandemic is what our life has become as of late. So I thought I'd give this presentation a little different flavor, a personal flavor from the execution that I've been responsible for, and the deep and granular insights that I've learned, which I thought may be worth sharing with colleagues from other countries. Now, when I got your letter, the letter said that we're interested in learning about the variations in outcomes. Can government policies account for that? Could the strength of public health systems account for that? Is citizen mobilization a factor? What about vaccine availability? Now, just to put things in perspective, in Pakistan, we are currently in the 4th wave. We have less than 29,000 deaths. As far as vaccination is concerned, we've administered 66 million doses, and 21 million individuals, which is about 10% of the country's population, is fully vaccinated. The vaccination campaign has picked up significant momentum, and by and large, we are with great humility, I'd like to say that we are very pleased with the way the country has dealt with the pandemic. The normalcy index, which the Economist has published, placed Pakistan 3rd. So with great humility, we're very proud for that, and fingers crossed, because the pandemic is still not behind us. Now, I'm not going to give you a typical presentation about the trend lines and the epidemic curves and the public health statistics. But I just want to give you a little bit of a flavor of what the enabling factors have been back in my own country about the relatively better performance of Pakistan amongst the South Asia peers, both with respect to the public health outcomes, as well as the livelihood outcomes and the economic outcomes. The enabling factors have been, well, firstly, to start with high-level political attention and support for the needed action. Ever since the pandemic began, our Prime Minister has had this habit of discussing it virtually at every cabinet meeting and discussing it fairly threadbare. Discussing the response and also discussing the balancing act between health and livelihoods. And secondly, Pakistan has had a whole of government and a whole of society mobilization to address this challenge. And with the example that I'm just going to illustrate with a bit of granularity, you will really see this come live. Thirdly, there has been an institutional approach to multi-sectoral collaboration. Now, as Ashish mentioned, and you probably know that my background is in the area of non-communicable diseases, where the whole of government approach, multi-sectoral collaboration, whole of society approaches were the bread and butter of the institutional response. But we always had this sense of these institutional attributes being very nebulous when we used to talk about them, because we never really saw them at play at a scale that we did in this pandemic. And I'm sure that must have been the case for many other countries. But in my country, we truly took an institutional approach to multi-sectoral collaboration. Our government developed what is called the National Command and Control Center, which became the rallying point for decision-making, for convening, for engagement across the layers of the government. Because Pakistan is a federal polity, there are many other South Asian countries that have a federal system, and you all know how complex it is to make decisions at different levels of the federal system. So the National Command and Control Center became the rallying point for decision making across the federating polity, across the various ministries, which had different roles in execution, and between the civil and the military, because the military played a very proactive role in the response to the pandemic, and across the public and the private sector. It also became a rallying point for problem solving and decision making. So it was truly an approach to multi-sectoral collaboration, not just in letter, but also in spirit. The fourth thing that we did was that we ingrained and embedded a culture of data-driven decision-making right from the word go. So every morning, the briefings at the National Command and Control Center would start with a stock take of data. And slowly and gradually, we started with the bare bones, and we started with whatever little was available. But over a period of time, the approach to data collection, the approach to data collation, the kicking in of the approach to data analytics, the use of AI, the use of modeling projections became improved day by day. The fifth thing that we did was to use the entire might of the government to address the pandemic. For instance, the cell phone ringtones, when you call somebody and the cell phone starts by telling you which wave we are in and what we should do, and how important it is to do A and B and C and D. Every approach to mass messaging was mobilized. So whatever the government could do, it did to mobilize its might to leverage all possible avenues. And then one of the key success factors in the response was the very large package of assistance that the that the government mobilized. And of course, there were many other economic packages that the government rolled out as well. But what I'd like to talk about in a little bit of detail is this emergency package of assistance, because through that, I want to highlight some of the institutional attributes which I think are important for knowledge sharing, because these are learnings that we have, and I thought it would be useful to share these. The package of assistance was called SAS Emergency Cash. SAS is the name for a multi-sectoral, multi-component social protection and poverty alleviation initiative, which is executed out of the ministry I run. And it has 4 pillars with a human capital development component. There's a governance component, there's a social assistance component, there's a jobs and livelihoods component, and then there is a human capital development component where health is embedded. And the emergency cash instrument is one of the instruments meant to come into play during the cases of an emergency. Before I talk about SAS Emergency Cash, I just want to, with apologies, want to be self-reflective for a minute, because when we were confronted with this situation, I just reflected back on my first tenure as a minister, which was back in 2013. I was responsible for several ministries, and I was a minister only in an interim government for a few months. And when I got down from that role, I wrote this paper in the Lancet, Reflections from My Tenure, in which there were certain key lessons. And one of the lessons was that in order to turn around a solution, you need to draw on competencies from various sectors. You cannot, if there's a health solution or an education solution, you need to borrow competencies from technology, you need to cut across sectors of the government, you need financial instruments. And unless you have the ability, the leverage, the mandate, the facilitation to tap these whole of government capabilities, it is very difficult to turn around a holistic solution. And that is one of my key learnings, which I brought into play as we executed these cash operations. Secondly, that transparency and accountability and being apolitical in your approach while in government really pays the dividends. And that's something I'd like to illustrate as well. And the third thing was the importance of real-time evaluation and attention to design. So as I take you through, this bit of journey, these are some of the key learnings, and then there were others as we executed. So before we come to the learnings, let me tell you a little about how SAS Emergency Cash was executed. The context was that when the pandemic hit, of course, there was a health response that all of you are deeply familiar with, and you probably had a very deep conversation around that this whole day. But in addition to the health context, there was also another very pressing context, the context of livelihoods. Now, in my country, which is, by the way, the 5th largest in population terms, the 5th largest country in the world, there are 24 million breadwinners who are either self-employed in the informal economy or who subsist on daily or piece rate wages. And life for them virtually came to a standstill when the lockdowns were imposed, when intercity transport was suspended. So there were 160 million individuals in distress. That's 2/3 of the country's population. And I recall before we came out with this package of assistance, people would call me and tell me, we want to help. We are stocking up rations in our car, we are going out, but we are attacked because there's so many people who are hungry, desperate, and stranded in major cities, unable to go back without daily wages. So it was a very dire situation. We were on the brink of a humanitarian catastrophe. The government decided to give an emergency cash package of assistance for 17 million families. Over $1.5 billion was allocated, and our projections was that it would impact half the country's population. This was the largest social protection program in the history of the country. And mind you, it was rolled out in the direst of situations when lockdowns were in effect, where people could not congregate. And here we were, we had to execute this large program because otherwise 2/3 of the country's population was in distress. So what did we design? When we designed the tech, we had to use technology. And because SARS as a program was developed back in 2019, early 2019, and we were there talking about design in March 2020, we had the benefit of having developed some systems that we could leverage. One of them was a SMS request seeking mechanism. The other was a data analytics mechanism. The third was a biometric payment system. So we joined the dots between these things. And we relied and leveraged on competencies in various government systems. Pakistan is a national repository of identities. So every citizen has a unique national identity number, which is one of the assets that we tapped. Cell phone use is fairly pervasive, not smartphones, but feature phones, which is something that we relied on. SMS usage is fairly well advanced. That was one of our assets. We have a national socioeconomic survey data, which we leveraged. And then there are commercial banks which could execute biometric payments for us. So what we designed was an SMS messaging mechanism. Citizens were asked to message their national identity card numbers on 8171. Once that number came to us, we checked it against survey data. We ran it against wealth proxies. And then we sent SMS messages back to the individuals who were eligible, and we staggered payment message. So we sent them a message saying you're eligible or you're ineligible. And then we put them in a queue, sending them messages to receive their payments at the outposts of commercial banks. So there was a this was a data-driven analytical process, and acceptance and regret messages were triggered by SMS. These identity numbers were put in different data buckets. When the identity card number would come, it would check it against the data bucket of government servants. Secondly, those that were ineligible. Thirdly, in the survey pool, then in the data analytics pool, and these messages would just go out. The wealth proxies that we used were international travel, ownership of a car, income level above a certain category, the phone consumption, their ability to access other services, which indicated wealth status, ownership of land, and government employment. So thousands of payment camps were established by commercial banks in virtually every village and union council of the country. And once the payment messages were triggered, people would go, they would do a biometric verification, and their identities would be authenticated, and they would receive an equivalent of $75. It was a very watershed moment for the country to really help cement the bond between citizens and the state. And all across the country, they would keep these massive queues of people lining up to receive their cash. And after that, they would sit quietly in their homes, not expecting to have work for at least 2 months, while we then expected the pandemic would abate. But since then, we had to do a second round of cash because, as I said, we're in the 4th round now. The spending breakdown was such that 93% of individuals reported that they used this emergency cash for food. Whilst we were executing this program, there was massive public engagement on social media, in newspapers, on radio, on television. There was a lot of instructional content that we got out there. And our Prime Minister, we made sure he was very involved. He was the one who sent the first message and got a message back saying that you're a government servant, you're not entitled for this service. And then the numbers 8171 became very iconic for government assistance. So everybody knew about 8171. Even a child on the street knew 8171, to such an extent that we've labeled one of our programs 8171, even though that does not have an interplay of SMS messaging. We were constantly in the field. We would take the Prime Minister to different camps, and his presence in the field helped to signal comfort to individuals, cement the state government relationship. And of course, these were opportunities for us to also talk about how important it was to social distance, how important it was to comply with the government messaging. So the SARS emergency cash helped with two things: the cash disbursement, as well as confidence in the government and confidence in the government's messaging. Now, the engagement with the private sector was a very important component of what we did. So because we received 66 million unique requests for assistance. That's a massive number. Overall, we received 139 million requests for assistance, but when we cleaned them and removed the duplications, it was 66 million. And as I mentioned, these outposts and camps were in different government buildings, but it was the commercial banks that would go with their gadgets and their point of sales and make the payments possible. The federal-provincial partnership was a very important component because the provincial government would give us the space, and then in many instances it was the citizens that got mobilized. So the citizens would come, they would put up, sometimes shelter, bring water, bring chairs, and that was. So it was an enormous watershed moment for the country, where not only the federal government, but also the provincial governments got mobilized. The citizens came forward to help. The local politicians took responsibility in their own areas. Now, because the 8171 was hugely successful, when our vaccination campaign was designed, they designed it on similar principles. So the same data pool, the same algorithm for messaging, the same mechanisms, the same IT infrastructure, and the same way of communication. So our campaign was 8171, and the vaccination campaign came to be known as 1166. So in effect, the pandemic was also an opportunity to test a system at scale and help bolster and cement better the government-citizen relationship through that approach. The other attribute of what was executed, and I think in terms of the lessons learned, which is important, is the aspect of transparency. Because previously there was a tendency to keep the granularity of the social assistance under wraps. So there was a reluctance on part of past governments to share where the money went, which province got more money, which got less money, which union councils were getting higher injections, etc., etc. What was, and we put everything out there on a publicly accessible portal, which was updated in real time. And you're just seeing the one screenshot of the portal, but if you scroll down, there is a search engine which allows you to go into drill down at a provincial and district level to go to the last mile. And that really helped to inspire confidence. We also put in place portals that were responsive to citizens' needs. So they wanted to check their status. We made information available to them. Individuals wanted wanted an open access complaints portal. We made that available to them. One of the things that really helped with signaling the importance of, I beg your pardon, signaling the true intent of the government in this intervention was the political neutrality with which this work was done. I'm showing you these two parallel bar charts. Now, Pakistan is a federating polity, and in a federating polity, there are mechanisms of fiscal, there are fiscal formulas of resource sharing, and different countries have different formulas, but ours is based on population. I'm not saying that that's the right formula, but its gaps notwithstanding, there is a formula according to which provinces get resources according to their population. And we have 4 provinces, 2 federating units. And one province is governed by a political party which is in opposition to the political party that runs the federal government. By population, its share was 22.5%. But because it had a high prevalence of poverty, and because the major cosmopolitan city was there and a lot of workers were stranded there, it ended up, a lot more people ended up getting qualified for assistance. And hence we changed the parameters, the initially agreed parameters, and that province got 31% of the assistance as opposed to 22.5% of the assistance. So in our experience, if you are politically neutral with a program, if you're rule-based, if you're transparent, if you're using technology in ways that are citizens empowering, the chances of success of your program are much higher. And as I would like to reiterate when I conclude, this experience has had implications for how we hope to execute programs in the future as well. And that's why these learnings are important, and that's why we're sharing them with you. The other thing that we learned from this program was that real-time evaluation and response is absolutely critical to the success of this initiative. And I want to highlight this with some examples. Now, this massive program rolled out in emergency. Of course, you did not have the time to pilot test it and to learn and to do an RCT and to do a process evaluation. You just had to roll it out, and what we embedded in it was simple real-time evaluation, listening to voices from the ground, doing an analysis of the social media feed, and then ascertaining on a day-to-day basis what's gone wrong and how do you remedy it. So I just want to give you a little bit of flavor of what transpired. The first week when we rolled out this program, I went to a laborers camp and I asked them, how many of you know about 8171? And everybody raised their hands. But when I asked how many of you have texted, only half of them did. And I learned something and felt extremely ignorant about the ground reality that people could not text. They had feature phones. All of them had feature phones. They could listen in, they could make a call, they could not read a text. And of course, that day on national television, on national radio, we had this massive campaign asking volunteers to text on their behalf. If I had not gone into the field, we would not have known about that. The other thing, a problem that we ran into were the fraudulent deductions. So the retail agents at the point of sale, realizing that there was so many, that such a massive amount of money was being pushed out, started deducting money, 2%, 3%, as high as 10%. And we took very strict notice of that. We reached out to the relevant agencies, did all that was required, and we really bolstered the registration of complaints and through the formal route, and put many people behind the bars, to compel an accountability and also as a deterrent. We also learned that people need to be educated, and one of the best ways of educating them is to ask them to read the amount, on the receipt. And there's a fair bit of advertising centered on the receipt itself. We were confronted with cyber attacks, and to hedge against those, we ultimately created a cybercrime wing and take a number of different measures to secure the point of sales machines through which the payments were being done. We also experienced that 7% of the individuals were experiencing biometric failure because of faded fingerprints, because of a whole host of other factors. And we had to literally within a matter of a week develop a solution to deal with biometric failures and arrange for them to be paid through a different route. There are limitations of data-driven messaging. And when the CNI, the National Identity Card number would hit the data pools and the messages would get triggered, there were algorithms to identify the deserving. And if the deserving individual had died and had not registered the death certificate in the relevant agency, we had no way of knowing that the deserving individual eligible to receive the payment in a particular household had actually died. So the first day when I was on radio taking live calls, a young girl pointed it out, and we immediately went back to the drawing board and said, yes, this is one of the limitations. So we had to do a workaround how to pay the next of kin, and these are fairly complex processes to tackle on the go, and then to cascade into implementation, to take the relevant approvals at different levels, and then also to execute. Another simple thing that we found out was that the system would not, if the national identity card number of an individual was expired, the system would not allow them to receive payment. So there was a certain amount of lobbying we had to do to make sure that this conditionality was waived off. Another bottleneck that we faced was with the branchless banking retailers, because the branchless banking retailers suddenly went on strike one day, and they said, we are working in a very different environment. Lockdowns are in effect. Section 144 is in effect. All shops are closed. There is no commercial activity. And here we are being forced to make payments to people. You are putting us at risk. You're not even remunerating us well, because the commission that you give us, you levy a heavy tax on that. And we scratched our head and said, well, they have a point. We've got to take a fiscal measure to give them a higher incentive at this dire time. So I took a proposal to the Economic Coordination Committee of the Cabinet. They turned it down, saying, you can't ask for a tax break at this time. We are in an IMF program. And we were really in a fix. So the next day we were going to a payment camp with the Prime Minister, and I told him, look, we have a problem. So the Prime Minister intervened to be overruled that. We got it approved through the cabinet, and then once the decision was taken, then we had to work, because once you give there's a fiscal decision of that nature, there's a very complex approval process. So late at night, we'd be speaking to committee chairs and convening meetings the next morning to make sure that the appropriate decisions were taken at the provincial levels, because some of these taxes were federal, some of these taxes were provincial. So the point I'm trying to highlight is that you roll out a program because you have to. Ordinarily, you would do a conceptualization, a proof of concept, learn lessons, write a report, do a pilot, write a report, do an evaluation, then go full scale, embed evaluation in the case control post-experimental design, take your time to collect data. But here we were in 10 days, we had to roll something out. We had to pick on whatever we had, design something virtually on a blackboard, get rolling, and then on a day-to-day basis, decide what was wrong, and then fix things on the go. And it was an enormous experience. So the know-how in designing and implementing a massive national program in real time, in a context of complexity and uncertainty with speed, the know-how gained was truly enormous. I don't think we could have ever gained knowledge of that kind under normal circumstances. And in effect, that at least to the extent of my ministry, it's embraced new ways of government functioning. It's made the government more agile, more data-driven, more ambitious, more forward-looking. And it has really helped with the digital ways of working. And I'm sure that is something that is across the board, but the digital ways of executing and the reliance on that. So there is, of course, a legacy. There is a legacy of the program. It has helped us with the great global reimagination of social welfare, which was predicated in SRs. It's helped us with gender objectives, with financial inclusion objectives, with governance objectives, with objectives of digitization. I recall every day during that very busy time when I'd come back home, I'd write a piece of a report. So that report is now publicly accessible. Very happy to share the URL with you. So I think this is my last slide, but what are the big picture lessons? The big picture lessons are that if you want to innovate, innovation is not synonymous with the use of technology and one isolated silo of technology. If you want to innovate for scale, for public good, for large-scale executions at scale, you've got to join the dots between process, systems, and technological innovation. And you need to be daring, and you need to push the envelope, and you need to push the limits of what's possible. Secondly, when you execute, when you solve problems, the solutions do not come in packages with the names of ministries written on them. You need to have the agility, the ability to reach out to other counterparts within the government, across the layers of government, in the private sector, in the political system, and at the citizens level, to get from every sector what is required for your execution. Thirdly, the role of transparency, accountability, and political neutrality and rule-based functioning is absolutely fundamentally supreme. Because if you are trying to game the system for personal gains, for political gains, for an unwarranted leverage, people at the receiving end are the first to see through your intentions. And then the other learning for me was that real-time evaluation, remedial action, and communication is absolutely fundamental. A lot of times we think that we've written a policy, we've ticked the box, or we've written a policy, we've got an execution plan, and we've given a contract to whoever, and things will roll out. That's not the case. you need to monitor execution on literally a daily or a twice daily basis with clear indicators, with clear accountability, with a culture of delivery. There has to be remedial action embedded in whatever you do, and then the constant communication. The recipients of your of whatever you're trying to deliver, whether it is a health or social protection or education, unless they understand what you're delivering, unless they understand how they have to take the benefit from that delivery, and unless you understand what their problems are and are committed to action, you will not cascade benefits on the ground. So, so I just want to end by saying that I thought I'd throw in a little bit of this different flavor into the discourse today, which I'm sure must have been very public health centered. But I do that with a view to sharing lessons from this very large scale execution. I don't claim that we've aligned the sun, moon, and the stars, but we were able to help our people at a very difficult moment and avert a humanitarian catastrophe. There are some very important learnings. And I would say that it has really emboldened us and a government and really helped cement the relationship between people, citizens, and the state, which is ultimately what governance is about. Thank you very much, and over back to you, Ashish.
I think, I'm not sure if I'm visible there. I think that this is the, well, thank you so much, Sanya. It's great to see you again. And it's wonderful to hear about the lessons that you have shared with us, about transparency and accountability, the whole society and whole government approach, and about evaluation and communication, particularly. So important to share those lessons and to bring, and also to about the technology, the way that the government has been using technology, and we can see how it's made a difference and how Pakistan has really not been hit as badly with COVID as everybody was fearing and expecting. And I just want to say that it's we met first when you were doing Heartfile. That was many years ago, and you're still doing Heartfile. It's wonderful to know that you're still doing that, and you were part of our Aman Ki Asha program with Peace with India and Pakistan. And this whole COVID situation has really showed us the need for a more regional approach and for more cooperation between in the whole region as well. And I'm sure there's a lot of questions on the Zoom chat, and there are people here who might have questions as well. I just want to ask a couple of questions to begin with, if I may. One is that I wanted to ask you about the, in the interest of the transparency that you were talking about. You mentioned that the data, that the BISP, that the Benazir Income Support Program, which you also chair, which I think SRS is linked with that. I'm not really sure how that works, but I believe that the database of the BISP was supposed to be updated in 2015. So if you could, like you're talking about the 66 million, you said you had unique requests for help, and it's wonderful that the government was able to help so many people, and we were able to see how it's really had this impact. But I'm just wondering, in terms of database, has that been updated?
So, well, first of all, Veena, my apologies. My screen was showing the slide only, so I didn't see you. It's a pleasure seeing you.
Oh,
again.
I was sitting in the front on the other side, so that's fine. Yeah.
A pleasure to see you again. We've worked together on so many different fora. I'm not associated with Heartfile anymore, but I'm full-time now working with the government. In terms of your question, we have just completed the SAS survey, which is the National Socioeconomic Survey. It's a digital census, Pakistan's first door-to-door digital census. So you'd be pleased to know that that has come to fruition. In terms of BISP and ASAS, just to quickly outline the difference. So ASAS is an umbrella initiative comprising 20 programs and 292 actions, policy actions linked that are pro-poor. ASAS has about 26 executing agency, and one of them is BISP, which does the cash transfers, but there are many other executing agencies of ASAS because it's an umbrella program. But to answer your question, the survey has been completed.
Oh, that's wonderful to know.
Yeah, yes, but just to clarify, when we executed ASAS emergency cash, the survey was not completed then, so we could not, and the previous survey was 10 years old, which is why we had to rely on data analytics as well and use the wealth proxies. So when the information would come first, we would check it against the survey. A lot of people were not in the survey, and then we had to use the wealth proxies on them.
Great, thank you so much for that. And I'm going to ask if there's any questions from the people who are here or from the Zoom chat, which Matt, you can let me know. And are there any? I don't know. Does anybody here have any questions? I'd like to open the floor up for any questions to Dr. Nishtar in terms of her very comprehensive presentation about the situation in Pakistan. And if not, then maybe I'll just, I want to share with you something what Dr. Jha shared earlier. So this, earlier this year, we started this South Asia Peace Action Network. It's a coalition of many different organizations and individuals around the region. And the need for regionalism that I mentioned, that the COVID pandemic has really underlined the need for regionalism and cooperation between all our countries. And we saw that, Sanya, as you know, before in our other natural disasters, the Kashmir earthquake, the floods, in India and Pakistan, elsewhere, the need for people to come together. And so we started this. I don't know how this can come on the screen. The South Asia Peace Action Network. I don't know who it's called. It's South Asia Peace on the web. And Matt, can you help me with that? So we passed a resolution. We had this seminar on exactly COVID and South Asia in June, and we had some really excellent, NGOs, activists, health professionals joining and having this discussion. And we passed a resolution on the need for regionalism in South Asia at this seminar. And I'm sorry, I'm not able to, I don't really know how to operate the system, so I can't bring it up on the screen. But if you go to southasiapeace.com, the resolution is on, there's a tab that says resolutions, and there's the resolution about healthcare and regionalism, which is signed among others by Amartya Sen, is on that page that people can still endorse if they would like to do so, which I had wanted to put up on the screen to share with the audience here and people on the Zoom as well, but I'm not sure how to operate this system. So would anybody like to add any thing or comment, Dr. Jha?
Yeah, can I just, I don't know, Sanya, if you can hear me. Oh, here we go. Sanya, I don't know if you can hear me. One of the things that I would be your thoughts on is this issue of regionalism. I've been watching what has happened with really the remarkably good work of the Africa CDC. We're seeing other regional entities really step up in this pandemic. And it has made me start thinking about the broader question of the global health architecture that we have, where so much of it has centered around WHO and so much of it is centered around Geneva. And obviously, there's always been the question of regional WHO things, but this gets beyond WHO and regionality to a more comprehensive view of regional efforts as a way to deal with health crises. And I wonder, sitting at your perch, how you see the rise of regionalism as a part of this pandemic response, and most importantly, what it means after the pandemic is over.
Well, I think that we will need to go to the drawing board on many things once the pandemic is over, because right now countries are so consumed with the response and in preempting the next wave and in preparing. And I think vaccination is something that is the front and center of national health policies at the moment. The entire might of governments is being marshaled towards this one target to escalate vaccination, and as we all understand, that needs to be done. There was a phase earlier on when we were all talking about the number of ventilators and bed capacity and the laboratory infrastructure and the rest of it. But once the dust settles down and once we know that the pandemic is behind us, and hopefully that will be soon, we will have to go to the drawing board on many things. I mean, on the domestic front, we will have to think about disease security in ways that we used to think about when the first red herring was back in 2005, and for some time the world rallied around the concept of disease security, and they were and a framework was agreed, and then of course we all forgot that we needed to invest in public health systems and fix our legislative frameworks and the whole host of health systems interventions that have to be done to achieve the target of disease security. So we will have to go back to doing that, because right now we're in a very reactive mode, even 2 years down the line. But alongside that domestic piece of health system strengthening with public health at its core, with disease security as an endpoint, we will have to do a great rethink of how things need to be redesigned, how the global health architecture needs to be redesigned. And I'm sure this is very much on Tedros's mind as we speak. This is a time for change, and of course, your question about how to bolster the regional capacity of WHO offices, because let's not forget there are regional offices. Let's not forget that they have a mandate, and let's not forget that there were shortcomings there. So that whole piece has to be rethought. The whole piece about what kind of regional competencies and capacities could be shared, for instance, within South Asia, and how and what kind of capacities could be best centralized to benefit from economies of scale. That piece has to be thought through. What about non-communicable diseases? I mean, we've seen how non-communicable diseases have interplayed with the mortality and morbidity within this pandemic. How prudent is it to continue to brush them under the carpet? And what would it take to mount an effective response? So I think that we will need to think through many of these things once the pandemic is behind us.
Thank you, Sanya. I think that really underlines one of the things that we brought up at our seminar in June as well, about thinking of healthcare as a basic human right, and not as just not something that should be handed to corporates. And as you know, the healthcare in Pakistan, in Bangladesh, India is very heavily privatized, which is one of the problems, which is one of the basic issues that our countries face. I do see a hand up over there as well, but I have a question from the Zoom chat as well, which I will read out, asking about how can the intergovernmental platforms in the South Asia region be strengthened for improved governance at the national levels to address these issues that you've talked about: poverty, deprivation, inadequate access to health, and disruption of livelihoods. And that's a question from Vinod Menon. Sanya, and I'm going to ask the person here, if you had a question, maybe we can have both of those questions and you can answer them both together in the interest of time. And if you would identify yourself and ask your questions also, and maybe Sanya, if that's okay, you can take both the questions, and then we have a couple of comments from two other speakers that I would like to go to.
Thank you very much. My name is Grayson Robinson, and I'm with the Executive Master's Program for Healthcare Leadership. And one of the questions that I have is regarding the long-term care landscape within Pakistan. And I'm curious to know if you have a privatized healthcare system, what do your long-term care communities look like? Or is it a family-based systems structure where you have intergenerational caregiving that occurs? Because we are seeing the breakdown in many different areas of traditional family caregiving models as certain nations we're dealing with an aging populace. And there are other nations that are already ahead of ours that in the aging wave. So I'm just curious to know how would you define the long-term care landscape within Pakistan, and what is the community structure look like as you look out towards 2035 and 2049, 2050? Thank you.
So, so on long-term caregiving, Pakistan is a very cohesive community structure and a very cohesive family structure. So in terms of in terms of long-term caregiving, there is a strong intergenerational aspect. Up until now, there really was no concept of old age homes. There was no concept of carers. It was the daughters and the daughter-in-laws and the sons that would look after mothers and fathers and the in-laws, and that tradition continues. And I think it is so very important for the elderly to have that mental stimulation and that feeling of care being delivered by their loved ones at that particular age. So that fabric is very, very strong. Has been and is still very strong, but as of late, there have been isolated instances of very isolated and sporadic instances of children abandoned, of the elderly being abandoned, and in fact, we have legislated on this subject very recently to ensure the rights of the elderly and to develop the frameworks for caregiving and to give protection to the family support that our society and the government and the state thinks is so fundamental to our societal fabric. On the question of regional platforms, yes, regional platforms are very important. I belong to that camp, and for a very long time, as Bina will bear me out, have been a strong proponent of technical collaboration, of the need for regional platforms that can facilitate knowledge sharing and capitalizing on sharing of experiences, because I think that there have to be some things where, some aspects where we must rise above differences and facilitate academic interaction and knowledge sharing and the learning of lessons. Countries in South Asia have a common colonial imprint on their systems. I'm not saying that's a good thing to have or a bad thing, or that notwithstanding, what I'm trying to indicate is that there is a certain commonality within our systems. And therefore, a lot of times when we sit with colleagues from India or Bangladesh or Sri Lanka, we tend to, our problems tend to resonate. And when we talk about solutions, they seem to have a common meaning across countries as well because of the similarity of the system. So I always find interactions on the intersections of the social sector particularly very useful. And by all means, I think SARC should, it would be very helpful if SARC was a facilitative forum. SCO is another forum, ASEAN is another. And of course, there are many there are many bodies within the multilateral system which can act as spaces for convening, which can act as spaces for dialogue between countries within the region. For instance, the World Bank has the World Bank's definition of South Asia is very typical of South Asia, although the World Health Organization divides us into CRO and into the Eastern Mediterranean region. But as I said, some multilateral entities have a very classical definition of South Asia, and by all means, we should speak to each other and knowledge share. One of the things that I reflecting back on the time when I was in the WHO DG campaign, they were most parts of the world was so regionally integrated. Some of them even had common regulatory frameworks and they had common norms. So South Asia is one of the regions of the country which is the least integrated, which is the least collaborative, and all I can say is that it's
That needs to change.
losing an opportunity.
Yeah, that needs to change. I do have another question, but I'm not going to take it because you've already answered it in your presentation, Sanya, which is about the lessons that Pakistan has learned from strengthening these health systems in the public sector. And I think you've kind of talked about, well, maybe not, about, if you could quickly talk about that. It's from Ayaz Qureshi asking about strengthening public health systems in the public sector, especially in relation to health resources. If you could quickly answer that in like a minute.
The public health system is a component of the overall health system, and when it comes to strengthening of public health systems, particularly with a disease security lens, with respect to emerging and re-emerging infections, there is a specific laundry list. And as far as that laundry list is concerned, there were salient weaknesses. Despite a stock take that was done by the CDC, I think about half a decade ago. And of course, the pandemic was a wake-up call. Our government, as I mentioned, marshaled all its resources and whatever it had at its disposal to do the best that it could. And I'm first-hand witness to that. So the bolstering of the health system's capacity, the stepping up of the laboratory infrastructure, the training of the human resource, the procurement of the supplies, the medicines, the stepping up of the vaccine of our expanded program for immunization to ensure that to make the grounds for vaccination. Whatever was required in terms of the response has been done. But as I said, once the dust settles, we will have to, we actually already are making those strategic investments, going to the drawing board. Our cabinet has recently approved the framework for a new CDC-like structure. So it's not as if we are just embroiled in the response and the vaccination. Some systemic public health interventions are quite further along in terms of deployment. But let's remind ourselves that this ecosystem is a component of the larger health system. And of course, in countries as large and diverse as Pakistan, you're not talking about one health system, you're talking about many health systems. For instance, there are many systems that are vertical, that have their own funding, their own human resource, their own delivery systems, their own accountability, their own governance. So the armed forces, there's a system that serves the armed forces. And there is a system that serves the retired armed forces personnel. And together, they cover more than the population of the Nordic countries. They cover them on universal health coverage principles. Then, of course, the government servants, the members of the judiciary and legislature are served out of the system that is not vertical, it's horizontal, fully government funded, but accessing services both from the public and private sector in financing terms, universal health coverage. Then there is another vertical system of private sector employees, where per capita contributions are made by employers. So standalone funding arrangements, vertical in terms of their own service delivery infrastructure, their own staff, their own governance mechanism. So Pakistan has 3 vertical systems, a horizontal system, and then what I call the mixed system, in which both the public and private sectors operate, and where out-of-pocket payments are a major means of health financing. It's a complex polity. It's a complex polity of health systems, and the issues in various health systems are very diverse also, in terms of funding, in terms of service delivery, in terms of information systems, in terms of drugs and devices, and in terms of its governance. So I'm not the sector steward responsible for health in our government, but I work very collaboratively with the health minister. And there are certain lines of reform that the government is undertaking. For instance, the drug regulatory mechanism. So there's an aggressive reform of the regulatory institutions that's currently underway. The drug regulatory mechanisms have been totally revamped. The human resource regulatory mechanisms, where there was a lot of rent seeking and inefficiencies and capture by the public sector, have been totally reformed with new legislative frameworks. As far as the service delivery is concerned, the government's focus is more on the hospital side of reform, where new frameworks allowing more autonomy to hospitals, allowing more decision-making autonomy, financial autonomy, have actually been legislated. And that's quite a bold step. We need to see how that cascades into implementation and what the outcomes are going to be. And I'm sure once the dust settles, then then we will come to the primary healthcare side as well. But because we sit in the federal government, we are not so much responsible for primary healthcare, because that's in the domain of provincial governments.
Because of the provincial, yeah.
Yes. So Pakistan is, as I mentioned earlier, we are a federal polity, and about 10 years ago there was a constitutional amendment by virtue of which certain subjects were devolved, and health education were the 2 subjects that were devolved completely to the provincial level. According to our constitutional covenants, there are some responsibilities in the health sector which are federal responsibilities. Health information is one of them. And because health regulation is also one of the federal responsibilities, hence the focus on drug regulation, human resource regulation. Quality regulation has really been the blind spot over the last 70 years, and there are now beginnings of the development of a framework as a starting point. A hugely problematic area. And because we govern we are responsible for the federal territories, and a lot of hospitals are in the federal territory, hence the focus on hospital reform. On the financing side, the government has espoused universal health coverage, and the financing instrument through which universal health coverage is being executed is an insurance program where the government pays the per capita contribution of citizens, and there is a quasi-private insurer who procures services from the private market.
That's very interesting to know. I didn't know that. Sorry, I don't mean to cut you, but because we are running out of time, Sanya, and we have a couple of other people who I'm sure would, if you could stick around and also listen to them, that would be really fantastic. We have Malik, who's a postdoctoral fellow and incoming assistant professor of government at Harvard University. And after that, we have Umar Afzal, who's a PhD candidate at the political science program at Brown, and so they have very brief presentations. Thank you so much for your very intensive presentation and your detailed responses to the questions. I'm sure we could go on for a lot longer. This session was supposed to end at 1:30, which is 1:30 now, but we went over a little time because we started late. So I'm going to ask Michelle to come and share her, I think she has a brief presentation, and then Umar right after that. I won't get up again to introduce you in the interest of time, if that's okay. Thank you.
now 10:30 at night in
Yes.
Islamabad. So Sonia, if you need to sign off, we will more than understand and say thank you very much for joining us.
Thank you.
So is she? I don't see her anymore. Is she still here? Okay.
I am here.
Is Dr. Nishwa still? She's still got.
She's not done. Okay, so I'm going to be very quick because we're almost out of time, but Dr. Nishtar went into like a deep dive of the SAS program, but what I'll try and do is just give a general overview of how the pandemic has played out in Pakistan, how that compares to the other countries, some of the government policies that might have contributed to this success, as well as what I see as some of the basic challenges moving forward with vaccine rollout, given that vaccine hesitancy is actually quite high in Pakistan. So just some descriptive trends to start with. This is what the pandemic has looked like in Pakistan in terms of the number of confirmed cases per million people. Over time, as Dr. Nistar said, they've had 4 waves and we're in the middle of the 4th wave right now. And to put this in perspective, this is what the same line looks like when you compare it to Brazil, which is a country that's roughly the same size as Pakistan. So this should give you a sense of really how the pandemic has been controlled in Pakistan. Now, there's lots of reasons. The age structure looks different in Brazil. The median age is higher. There's also more sites where you can have deadly outbreaks. So there's more nightclubs and bars and old folks' homes and things like that that don't exist in Pakistan. But even countries that in terms of the age structure look similar to Pakistan, like India, have done much worse in terms of pandemic control. So this is again the same data, which is confirmed COVID-19 cases per million people. And as you'll see, the lines for India and Nepal are much higher than those for Bangladesh and Pakistan. So, what to take away from this is that, Pakistan has fared much better than a lot of its neighboring countries. And there's no reason to believe that underreporting is what's causing this. So there is underreporting, but underreporting is there in all of the neighboring countries. And we also have independent sources like Aga Khan University in Karachi, which basically shows similar positivity rates as official data. So it's not as if the government is sort of messing with the data and that's what's causing the trends that I just showed you. So could it be about vaccine rollout? No, because, so this is the data on the percentage of the population that has now received 1 dose of the vaccine. And compared to the other countries, Pakistan was behind India and Nepal for most of it. It just got past Nepal's numbers and it's still behind India. So it's not really about people being vaccinated. So what are some of the policies? I won't go into the ones Dr. Nishtar talked about, so there's no redundancy. But one of the things that she said, which really, when you talk to epidemiologists, like they say this was what kind of probably helped in Pakistan, and it was the data-driven, sort of real-time data-driven smart lockdowns. So there was a countrywide lockdown at the beginning. It wasn't sustainable. It was going to, as Dr. Nishtar said, lead to a humanitarian disaster because so much of the country are daily wage earners. And so what the government did was use very granular local level data on outbreaks to say this neighborhood is an infection hotspot and now we have to shut it down. So that was a lot more sustainable from an economic point of view, and it really helped contain the spread. And what's important to note is that Pakistan has a very extensive system of community health workers because of its efforts to eradicate polio. So it's one of the few countries, 2 countries in the world where polio is still there. So all of these folks, there's 250,000 of them, were mobilized with the help of the WHO to try and collect this real-time data. And then the government kept a very quick watch on where the trends were going and did what they call smart targeted lockdowns in specific neighborhoods. So SAS, the minister already talked about, and then lots of extensive public messaging, right? So you can't call anyone in Pakistan now without getting a public service message about COVID. They did a good job of acquiring the vaccine from China, even though we know it's not as good as the other vaccines, but they took what they could get. There's also more controversially penalties now for vaccine refusal. These vary across the different provinces, but in Punjab, for example, if you don't register for it, they might deactivate your SIM. They're also refusing to pay wages for public service workers if they don't get the vaccine. And then finally, Omar can maybe talk about this more, but the NCOC, which is in charge of all of this, is very heavily led by the military. And for better or for worse, the military is the most organized and trusted institution in Pakistan and has been there when the 2005 earthquake happened, when the 2010 floods happened, and so has this extensive experience with disaster management. Now, I'm going to end with what I think will be some challenges, and it would have been great to get Dr. Nishtar's view on what they're going to do about this. But I'll show you some public opinion data from July 2021. This is from Gallup, Pakistan. I can talk about the sample if you want, but I don't think we have time. But 55% of Pakistanis still believe that the threat from COVID is exaggerated. So that's the sort of downside of the government doing a good job with COVID, which is because people really haven't seen it get very bad, they think that it's exaggerated. And related to that, a third of the population, 37%, believes that COVID is a foreign conspiracy. So they think that Western powers are using it for some nefarious reasons. And then 44% of the population is hesitant to get the vaccine. This was 62% in December 2020, so we're doing better. But lots of people are worried that the vaccine has dangerous side effects. This is the same issue that we see with the polio vaccine in Pakistan as well. So people worry about things like fertility. A lot of people believe that natural immunity is better than getting the vaccine, or they're just not worried about catching COVID. And then there's also the outreach problem, which is 59% of the population, at least as of July 2021, did not know how to register for the vaccination. So the government might have to go further in terms of the public services messaging over there. But yeah, that's all I had. Omar?
So in the interest of time, I'll make this quick and brief. We had an excellent address from Dr. Nishta and an excellent brief presentation from Michelle as well. So I had 4 broad points in response to Dr. Nishta's excellent keynote speech. And staying true to my discipline, most of them are about the political aspects of Pakistan's response to COVID. So we heard from both Dr. Nishta and Michelle as well about Pakistan's focus on, firstly, data-driven technology. And I think really this has been a refreshing change in Pakistan's approach, not only in the health sector, but in government responses to any emergencies, period. So this digitalized approach that we heard from Dr. Nishtar essentially is grounded in the SMS-based, the text-based request-seeking mechanism that is most crucially linked to NADRA, which is Pakistan's National Identification Database Registration Authority. And then secondly, a biometric payment verification system that we also heard from Dr. Nishta about as well. And then this is backed by other technology related aspects, including, for instance, a web portal for the Prime Minister's COVID Relief Fund. If you're an international traveler who's traveling to Pakistan, you can use the Fast Track app. And similar text-based, SMS-based registration is also true for vaccination charts as well. So there's plenty of good stuff to recognize and applaud Dr. Nishta and her department about. But perhaps one of the key challenges here is that since everything is being linked to the National Identification Registration Authority, or to the CNIC number that every Pakistani should have, the unfortunate part, I guess, is that not everyone has it. And this is a big problem, especially if you're talking about women in the rural areas, or just about rural areas even. So I guess the challenge moving forward is to encourage more and more people to actually get the CNIC first, and then move on. Secondly, I guess another thing that I have been pleasantly surprised about has been Pakistan's civil military coordination in handling the COVID pandemic. So remarkably, for a country that has had historically unstable, even poor civil military relations, Pakistan has been actually a great example of smooth civil military coordination over the last year and a half, especially as Pakistan's response to COVID-19 is concerned. As Michelle mentioned, the NCOC, the National Command Operations Center, is where the civil military coordination comes together. It's headed by Asad Umar, who's our planning minister. and who's supported by a sitting incumbent 3-star general. So you can see that this civil military coordination extends all the way up the hierarchy. Third, I think maybe Dr. Nishta touched upon this somewhat, is Pakistan's reliance on ad hoc measures in combating and in responding to COVID. So what this essentially means is that I would maybe push back a little on the notion that Pakistan has adopted an institutional approach to multi-sectoral coordination that we heard Dr. Nishta talk about. I would personally feel that there's still plenty of room for this institutional framework to be developed in order to undertake a more coherent national response to the pandemic. But importantly, what happens, unfortunately, is that when COVID response measures are driven by ad hoc executive ordinances, including presidential orders, their future can be somewhat uncertain and inconsistent. And the reason is that they eventually need to be presented to and approved by the Senate and the National Assembly within a stipulated time frame. So on the relevant authorities concerned, there's a certain amount of pressure involved to make this happen. And then finally, to wrap this up, there's obviously an element of politics involved here as well. And that's me just being polite. And the first thing that comes to mind is sort of what Dr. Nishta was getting towards when she mentioned that we have an amendment. So I believe the specific amendment that she was talking about is the 18th Amendment of 2010. And what this amendment did was it transferred certain powers from the center to the provinces. And this is relevant for us today because, as Dr. Nishta also mentioned, health is then one of the things that is devolved to the provinces. So when we talk about Pakistan's responses to COVID-19, provinces are supposed to be at the forefront of responding to COVID-19. And we've had a political tussle over here, particularly between the center, led by the PTI government, and the province of Sindh, where the Pakistan People's Party heads the provincial government. And so the opposition parties, including the Pakistan People's Party, say that the 18th Amendment actually gave us the freedom and flexibility to chart our own COVID response, our individual COVID response. But on the other hand, there's a political tussle where the center, led by the PTI, says that the same 18th Amendment actually hampered our ability to craft a national, coherent national strategy. And this is very much a debate that's still ongoing. And finally, just a concluding note on the politics of Ehsaas, which is Dr. Nishta's flagship program. There's some political friction as well here, and unsurprisingly, that's also between the center and Sindh, where the Pakistan People's Party is heading the government. The Pakistan People's Party parliamentarians claim that Ehsaas is just an extension of the Benazir income support program. The center, led by PTI, pushes back against this, saying that, and rightfully I should add, saying that Ehsaas is a much bigger, much more comprehensive project than the BISP, as Dr. Sania also showed us. But I think what this ultimately points us towards is the need for Ehsaas to have a legislative backing and constitutional framework to be grounded in moving forward, because I think this will continue to be contested politically moving forward, and so this might be a way to get around that. And with that, I'll just conclude. And thank you so much again.
Thank you so much, Omar. Thank you, Michelle. Thank you, Dr. Jha and Sania Nishta, who's not here. And if anybody had any more questions, I apologize because we ran a little bit late, but we'll end right now. There's 15 minutes between now and the next segment, and there's coffee and tea outside, and it's a nice day. So
let's start at 2:05, and that gives us about 18 minutes to stretch, get some coffee. Oh, there's Sania back again.
Oh, okay, wonderful.
Sania, thank you again so much for joining us. It was terrific to have you, and
you could come here if you want. She can't see you. She can't see you.
I know you can't.
Yeah, so because of the.
Yeah, I think so.
I don't know.
Were you here for the last two brief speakers?
Yes, I was, and I wanted to have the opportunity to respond to some.
Please do. We did not realize you were still on, and we are thrilled that you were. So please take a minute. Go ahead.
Yes, I was. Thank you for those two excellent presentations. As far as Michelle's presentation is concerned, I would only say that in terms of the opinion poll, what comes out glaringly is that 59% do not know how to register, and that of course has implications for better communication. But I'm not sure which data source she's citing and what the sample size is, because of a lot of these surveys are Gallup surveys, which have a sample size of 1,000 respondents, and there are inherent limitations with that sample size. Our Omer, I think was the colleague's name, outlined some very interesting things, and both of and he talked about the civil-military relationship in COVID. Well, we were actually looking like we were actually looking at a warlike mechanism. So the response mechanisms that were invoked in our country had a warlike character. So there had to be civil-military collaboration, and it's worked quite well for us. He talked about three things that I want to quickly respond to. Firstly, the institutional approach, and he said that there should be the decision should be taken by Parliament. And I just want to clarify that there are certain decisions that don't need to go to Parliament. So there are the executive has a certain mandate and a remit and authority and prerogatives. And when you have a command and control center where different members of the federal and provincial government sit and convene, they have their own prerogatives to make decisions, and these are institutional decisions. And if they are taken through concurrence at a convening platform where multi-sectoral collaboration is institutionally enforced, then that is illustrative of multi-sectoral collaboration. But then there are actions and institutional actions that have to be taken on a longer term basis. And within the context of COVID, if that involves the creation of a CDC-like structure, then that requires legislation, and the process of legislation is a process, and the frameworks will come to the cabinet, will go to cabinet committees, will go to Parliament, and that cycle for several frameworks is currently ongoing, and things are in the pipeline. Secondly, he talked about the political rift between Sindh province and the federal government, and of course, as far as COVID is concerned, I don't know, is this a public conversation? Is this being openly relayed, or is this Chatham House rules?
Yeah, I think it's being recorded and it's public.
It's public, Sanya, so I think you should assume that it will be viewable to others.
Yeah.
Okay, so I would say that the dynamic of the collaboration at a technical level within the MCOC was very different. All provinces agreed, and all provinces followed the agreements. But what got publicly displayed was very different, because political parties will be political parties, and on television they will play to the gallery in ways that suits their objectives. But as far as COVID was concerned, and as far as strategic decisions were concerned, there was a level of coherence. But then there were times when things were played up in a very different manner. On the matter of BISP and SRs, this is a question I continue to answer. So SRs is an umbrella framework. It has 292 actions linked by theory of change, 20 large programs, out of which 4 are executed by BISP. BISP is one of the executing agencies of SRs, but there are many other executing agencies, and many large programs are executed by other agencies. And because one of the very visible programs of SRs is executed by BISP, and because BISP stands for the Benazir Income Support Program, this is the name of a former prime minister who belongs to a certain political party. That political party governs in Sindh province. Therefore, the politicians in Sindh and because SAS delivers on ground, it is a very successful program with great humility, I'd like to mention. Therefore, they like to take the credit. And I think it's unfortunate that, because I would like the public debate about SAS to be about quality and about challenges and about the challenge of communication and about what needs to happen to enhance and make improvements. But unfortunately, the public debate about SAS is always about these political trivialities. Yes, there will be a legislative cover. I know you're looking at your watch, Ashish.
Oh,
So
sorry.
this is
Not realize that was visible.
so this is my last 30 seconds.
No, I'm worried about you and how late it is, but I'm now totally embarrassed.
I work very late. So, so you have to understand that the legislation, so SAS is executing its programs through agencies. Some of those agencies have been created through a legislative mandate. Others are regulated through the Securities and Exchange Commission. Others are, so every agency that executes SAS programs has a legislative cover. The SAS legislation that we're working towards is not going to scrap names and put new names, because that is what's politically expedient. The SAS legislation is going to be about the social protection floor and the definition of entitlements and the way that we are running our one-window operations, and about the data sharing protocols. That legislation is on the anvil, but I just want to emphasize that, that we are not operating in a legislative vacuum. Every program is executed under rules and regulations by entities which have a legislative cover. And very soon I'm going to release a video explaining SAS. And I'm delighted, Ashish, for you to be taking interest in these broader things outside of public health. The government functioning and institutional functioning is common to health education, social protection, and at least the social sectors. And if you get the fabric of the government right, you execute well across. So governance is common across all these. Once again, thank you very much for having me here. I hope that we will have another opportunity to be in the same room soon.
Well, Dr. Nishar, thank you very much for those comments. And I just...
And please do not, please just, Ashish, you don't have to call me Dr. Nishar.
I know, Sanya, I know. It's just...
Call me Sanya all my life. Just because I'm in government, you don't have to.
Yes, well, thank you. And I will just say that the issues of governance and good governance and the way they relate to any policy, any well-crafted or less well-crafted policy are fundamental, and something that you have spoken about, championed, and really taught all of us the importance of thinking about that governance framework. And I was happy that you were able to bring that back in again today. But your comments were really all around terrific, and we're very grateful that you spent time with us today. Thank you. And I look forward to seeing you in person, Sanya.
And the same thing, you know, you talked about regionalism and how to instill new vigor and thinking into these institutes of global health governance.
Yes.
And I think the trick would be to start with transparency, insulation from capture, and good and impartial governance. So I'll leave it at this. And thank you again.
Thank you, and have
so
a
much.